When upright, the human spinal column provides the central structural support for the parts of the body located above the legs. Descending down the spinal column from the first cervical vertebra to the sacrum, each successive vertebra supports progressively more weight. The sacrum, which serves as the functional base of the spine, supports the entire weight of the head, neck, both arms, and most of the torso. In healthy individuals, even with severe sudden loading or alternating and diverse movements, the ligamentous sheath which extends from the base of the skull to the pelvis and the surrounding muscles maintain the exacting alignment of one vertebra on top of the other that is necessary to keep them from intruding on and harming the cord. However, after injury has occurred to the spinal column or ligaments which keep it aligned, even a slight movement can produce sufficient misalignment of a vertebra or intrusion by sharp bone fragments to cause compression, tearing, or cutting of the cord and resulting permanent paralysis. To minimize the possibility of such avoidable cord damage, when spine injury is identified or suspected, the EMT initiates manual immobilization of the head upon arrival and maintains it without interruption until it has been replaced by mechanical immobilization and ultimately immobilization of the patient's entire body, supine on a long board or other rigid full body length device such as the Sked or a Stokes litter. First, it is important to determine if spinal immobilization is indicated for the patient or not. Many patients with unstable spine injuries have evident gross signs or symptoms, while others may not. Although there is considerable controversy surrounding whether asymptomatic unstable spine injuries exist, there is little question that immediately post-trauma, pain may be sufficiently masked and other signs so subtle that the presence of an unstable spine injury can be easily missed in the field. To protect against this, any patient in whom, from the mechanism, damage to the car, or other injuries, the EMT feels spine injury is a reasonable possibility, should also be immobilized. In adults, motor vehicle accidents are the largest single cause of trauma. Most victims are found still sitting upright in the seat they occupied in the car. Therefore, an interim method or device must be used to support and immobilize the spine while the patient is brought from sitting in the car to lying supine on the longboard. For many years, rigid wooden half-boards were used for this purpose. As cars became smaller and individual contoured bucket seats prevailed over earlier flat bench types, the use of half backboards became increasingly difficult. In 1978, the Kendricks, two visionary brothers, invented the first functional extrication vest. By employing rigid slats sewn into a fabric vest, which secured around the body from the pelvis to the top of the head, they designed the first device which was flexible when inserted behind a sitting victim, but, once secured around the torso and head, would immobilize the patient's head, neck, and torso in the neutral inline position while the patient was extricated from the vehicle. The KED rapidly became the standard and prevalent device used while removing patients suspected of spine injury from a vehicle. Although a number of different brands were introduced, the KED and design of extrication vests has been little changed or improved over the last 20 years. After more than 14 prototypes and over 2 years of experimentation, Bud Calkin of SKEDCO and Alex Buttman, a leading contributor to the literature and recent improvements in pre-hospital spine care, developed the Oregon Spine Splint II. The improved immobilization and other benefits it provides are so evident that after you apply it only once, we're sure you'll agree it's the next generation and best extrication vest you've ever used. Like any extrication vest, the Oregon Spine Splint II, or OSS as it has rapidly become known, must be used in conjunction with a properly fitting, efficacious cervical collar, and is primarily designed to immobilize the spine of a sitting patient while he or she is moved from sitting where injured to a supine position on a longboard or similar device. Although an extrication vest or half-board device protects the spine sufficiently until the patient has been extricated from the car or other confined area where use of a longboard is not practical, additional support and immobilization to include the entire length of the body is required before the patient is transported. Therefore, the extrication vest and patient must be placed on a longboard or similar rigid full-body length device, and the vest and patient's legs immobilized to the board before further moving or transporting the patient. To provide increased protection against road shocks or other sudden jarring, the addition of a standard head immobilizer or taped blanket rolls against the head flaps of any extrication vest is recommended and should be considered. As with any new equipment, becoming familiar with the components of the OSS before seeing it applied will be helpful. To aid in identifying each and giving clear directions to the other EMTs assisting you, the straps and buckles of the OSS II are color-coded. The two straps which secure the device to the upper torso are orange and green, respectively. Note that the orange strap half is the top strap on the left side of the vest, whereas the orange half on the right side is lower and second from the top. Similarly, the green strap half is the top strap on the right side of the vest and second from the top on the left side. The straps are alternated in this way so that when the same color halves are connected, they will form a diagonal tie which goes from over the shoulder on one side to the armpit on the opposite side. The two straps used at the mid-torso are gray, and the straps which form the groin loops are black. To avoid confusion between similarly colored pairs of straps, the buckles are also color-coded, one white and one black. As they are the only straps which are not permanently attached to the vest, the two head straps are easily identified. The gray anti-slip pad easily distinguishes the forehead strap from the lower head strap, which goes across the anterior portion of the cervical collar just below the chin support. The anti-slip pad on the forehead strap can be easily replaced. If it comes in contact with blood or becomes otherwise soiled, while firmly holding the strap in one hand, grasp the pad in the other and peel them apart. Then take one of the replacement pads supplied with the OSS and lay it carefully along the Velcro on the center of the strap as shown. When the two halves of each buckle are fully inserted, a loud click is heard, confirming that the buckle is properly locked and will remain connected until the EMT opens it. To avoid the chance of accidental release, the locking tabs are indented in opposite edges of the buckle and must both be depressed simultaneously in order to open the buckle. A military version of the OSS II with more subdued colors for military or SWAT use is also available. In this model, instead of orange, the carrying case is camouflaged, the body of the vest dark green, and the left shoulder strap is brown. In all other respects, the regular EMS and military versions have identical parts and are applied in the same way. The parts of the Oregon spine splint do not need to be memorized. As you apply the OSS, its parts will be anatomically self-evident and, after only several practice applications, will be easily remembered.